Good day. I am Dr. Teke Apalata, a specialist in clinical microbiology, and welcome to our lecture series on meningitis. During this first part of our lecture series, we are going to discuss acute meningitis that involve mainly viral and bacterial meningitis. So I said that we will discuss acute meningitis, and acute meningitis involve mainly viral and bacterial meningitis. So, what is meningitis? Meningitis is an infection that affects the membrane that cover the brain and the spinal cord. So as you can see here, we have the brain. This is the brain, and this is the spinal cord. So the brain and the spinal cord are covered by membrane that we call meninges. Meninges are the membrane that cover your brain and your spinal cord. And those meninges are made of 3 layers, from outside to inside. So we can see here, the outside layer is the dura mater, and you have the arachnoid. Then inside you have the pia mater. So those 3, when they are inflamed as a result of an infection, we call that meningitis. Okay. So the causes of meningitis can be subdivided into infectious causes and the non-infectious causes. Non-infectious causes can be conditions like lupus, cancer, and some anti-cancer medications. And we can also have, a patient can also develop meningitis following a head injury or a brain surgery, mainly as a result of subarachnoid hemorrhage. You can also have conditions like a Guillain-Barré syndrome and multiple sclerosis that also give you signs or clinical presentation of meningitis. Okay, but we will mainly in this lecture series focus on infectious causes of meningitis. And in this first part, we will mainly discuss acute meningitis that can be viral or bacterial. Then in the next lecture, that is the second part of this lecture series on meningitis, we will discuss mainly fungal and tuberculosis meningitis, but we also have parasitic meningitis that also cause chronic meningitis. Okay, so the difference between acute and chronic, it's not mainly in the clinical presentation, but it's in the time that it takes for the way the disease presents. You know, during acute presentation, you will see the disease that starts just few hours to few days. Maybe it has been 1 or 2 days since the symptoms occurred, but in the chronic cases, the disease established itself gradually, maybe over a certain period of time, over a few weeks. Then the patient will tell you that he has been complaining about this gradually and it's slowly getting worse. So that's the difference between acute and chronic, but the clinical presentations might have similarities, as we can see during our presentation. So let's introduce this first part of our lecture with this clinical case study of a 28-year-old male patient with acute CNS infection, so central nervous system infection. So this is a case of a 28-year-old male patient who presents with a 12-hour history of a high fever, severe headache, confusion, photophobia, and neck stiffness. So you can see that those are classic signs of meningitis. But the key here is that all this only occurred 12 hours. So this patient has only a 12-hour history of these symptoms: high fever, severe headache, confusion, photophobia, and neck stiffness. So those are classic signs of meningitis. And because of just a 12-hour history, few hours history of the occurrence of these signs, so it already indicates you toward an acute meningitis. Okay, and it said that he has no significant past medical history and he takes no regular medication. So this is probably the only problem that we are going to focus on. Okay, so this gives you an idea. So what is your differential diagnosis? You already suspect that this is a case of an acute meningitis. So it might be either bacterial or viral. Okay, so that's in your working differential diagnosis, you can already suspect that it might be either bacterial or viral meningitis. Now, if we have to look at clinically, what can make the difference between bacterial versus viral meningitis? We also call viral meningitis aseptic meningitis. Okay, aseptic meningitis, or it's what we call viral meningitis. So clinically, you will see that both patients, whether you are infected with a bacterial or a viral meningitis, all patients will have, commonly they will present with headache. And they will all have fever. Except that in a case of a viral meningitis, sometimes the patient might have coryzal symptoms like running nose and so on. So that are usually signs of flu. So the patient might have that, but they all have headache, they all have fever, they all have neck stiffness, they all have photophobia. So in that regard, clinically, it's difficult to separate between bacterial and viral meningitis. Okay, but then there is a subcategory of bacterial meningitis that is caused by Neisseria meningitidis. Neisseria meningitidis, it's also called meningococcal meningitis, and usually it also leads to a sepsis, a disseminated infections. So that meningococcal sepsis presents, in addition to those classic signs of meningitis, it also presents itself with a specific or a characteristic petechial rash that you can see here in this patient on the back and also on the legs. This is what we call petechial rash. So the patient will have this petechial rash plus signs and symptoms suggestive of meningitis. So you will, by looking at this, you can immediately suspect that this can be meningococcal sepsis. Okay, but other than this subcategory of meningitis, the rest of bacterial and viral meningitis will look clinically similar. So let's come back to our 28-year-old male patient who came to us. So now, since you suspect meningitis, now you are going to do a spinal tap. So you are going to collect a CSF, cerebrospinal fluid. Then after collection, you are going to analyze this. Now the CSF analysis from this patient indicated that the appearance is cloudy and turbid. So if you hear of a turbid appearance, it means that there is a high concentration of cells, mainly white blood cells, that make the fluid to look turbid or cloudy. Okay, so like in this case here, you have 936 cells per microliter of fluid, of white blood cells. And here more than 95% are neutrophils. They are neutrophils. Glucose was found to be very low, below 40% of the serum glucose. So when you measure, you interpret the glucose level in the CSF, it's always in comparison with the glucose level in the blood, in the plasma. Okay, so then like this one, from the CSF is less than 40% of the serum glucose. And the protein level here, you see that it's very high. It's 3 grams per liter. Okay, that also make the CSF to look also cloudy and turbid. So this is suggestive of mainly bacterial meningitis. So why not viral? First of all, the appearance of a viral CSF during a viral meningitis is not cloudy, it's not turbid, it's clear. So you will see that the fluid, the CSF fluid is clear, not cloudy, okay? And when you look at the cell, the analysis, you know, at the early stage of infection, you can have increased number of neutrophils, but predominantly during viral meningitis, there is a high level of lymphocytes rather than neutrophils. Although at the early stage, you will have a tendency of a high level neutrophils, but mainly after that, after a few hours, you will have more lymphocytes. Okay, and the glucose level during viral infection, the glucose level in the CSF, it's usually normal. It's normal, okay? And the protein level, although it might be high, but it's not as much high as it is here. So looking at based on these findings, CSF result, we can already think more of a bacterial meningitis. You know, it's an acute and appearance of CSF cloudy, turbid, increased level of white blood cells, predominantly neutrophils, glucose level it's very high, very low. So you suspect more bacterial meningitis. Okay. So let's just refresh your memory of what is the normal CSF composition looks like. The first thing is the appearance of a normal CSF. The appearance is clear and colorless. You can see here in this tube, you see this is the normal CSF. You know, it's clear and it's colorless. You know, so when it becomes turbid, you know, and cloudy and turbid, you exclude the possibility of a viral meningitis. You think more of a bacterial meningitis. Now, the white blood cells here, usually you have very few, below 5 cells per microliter, okay? So no neutrophils should be present. So those 0 to 5 cells might be usually lymphocytes. You usually don't find the neutrophils. And, but all you need to be aware of is that the normal cell count should not rule out completely meningitis or any other pathology. So you just need often to match this with the clinical presentation of the patient as well. Okay, then the red blood cells here, usually it's less than 10 cells, and the protein, it's usually less than 1% of the serum protein concentration. So this is how the normal CSF composition should be. Now, the glucose level in CSF should be from 60% or above of the plasma glucose concentration. Now, in viral meningitis, the glucose level is normal. So this is how it will look like. Okay, the appearance will be also clear and colorless in viral meningitis. The glucose will be normal. But in bacterial meningitis, the appearance of CSF, we said it will be turbid, it will be cloudy. The glucose level should be very low, usually below 40% of the plasma glucose. And the opening pressure, the normal opening pressure is 10 to 20. That's the opening pressure. So you will see that this might also be high when there is an increased intracranial pressure. Okay, but in bacterial meningitis, we say that the appearance will be cloudy and turbid. The opening pressure will be high. Remember, the normal opening pressure is between 10 to 20, but in a bacterial meningitis, because of the increased intracranial pressure, so the opening pressure will be elevated. and the white blood cells level will be elevated more than 100 cells per microliter, but predominantly neutrophils. In more than 90% of cases, it's neutrophils. The glucose level in bacterial meningitis is low. It's less than 40% of the serum glucose, and the protein level is usually elevated. So that's the picture that you can see in a case of a bacterial meningitis. Now, when you suspect a bacterial meningitis from there, what are the next steps in terms of investigation? The next steps in terms of investigation is that you have now to request a gram stain from that CSF, so microscopy mainly gram stain, and cultures need to be done. You can also request a bacterial antigen test to be done from that CSF. You also need to request CSF PCR because you just need to make sure that you don't miss maybe a viral infection or maybe a other type of bacterial infection that might not be easily grow from the culture. It's also better to request for blood cultures to see if the infection is not disseminated. And it's also better to request a CT scan or MRI of the head, but just to try to rule out other intracranial pathology. So those are further investigations that you can request. So what are the etiological agents of acute bacterial meningitis? So the etiological agents of acute bacterial meningitis usually depend on the age of the patient. When you're dealing with a newborns or neonate, it means that below 28 days, So the most commonest causes can be Listeria monocytogen, E. coli, that is Escherichia coli, and a group B streptococca. So if you suspect meningitis among neonates, so think of those three pathogens, group B streptococca, E. coli, and a Listeria monocytogen. But among children, especially children below 14 years of age, you can suspect Neisseria meningitidis, Haemophilus influenza, mainly type B, Haemophilus influenza, and Streptococcus pneumoniae. So those are commonest pathogen for children below 14 years. So this epidemiological picture can change according also to the immunization history of the child. So if the child had maybe a vaccine against Haemophilus influenza type B or Streptococcus pneumoniae vaccine, so sometimes you don't expect those pathogens, but you can expect still those pathogens, but different serotypes that are not covered into the vaccine molecule. Now, if you are dealing with adults aged between 18 to 50 years, and older children and adults between 18 to 50 years, mainly Neisseria meningitidis and Streptococcus pneumoniae will be the commonest pathogen. Now, in adults above 50 years and all other immunocompromised patients, you can suspect Neisseria meningitidis, Streptococcus pneumoniae, Listeria monocytogenes, and any group gram-negative bacilla. And gram-negative bacilla can be able to cause meningitis, especially in immunocompromised patients. Now, if you are dealing with a post-surgical patient or post-traumatic patient, or any patient that has been in the hospital, for a specific period of time, then you can suspect Staphylococcus aureus, Streptococcus pneumoniae, and any gram-negative bacilla can also be suspected. So whenever you are dealing with a case of acute bacterial meningitis, the etiological agent will depend on the age of the patient. It will depend mainly on the age of the patient. Okay. So the treatment will also, it's better to do a directed therapy for bacterial meningitis, usually to try to see if you can get the antimicrobial susceptibility result, but usually Streptococcus pneumoniae, usually if depending on the MIC of this microorganism, if it's around 0.06, the MIC, you can still use benzyl penicillin, but otherwise it's better you use a third generation cephalosporin. You can use a third generation cephalosporin. Okay, so in many cases, third generation cephalosporin can be used and they can be very effective. So let's then look at this second patient. This patient is a 38-year-old female patient who presents with a 24 hours history of headache, photophobia, mild neck stiffness, in addition to coryzal symptoms. Now, this you have, it's definitely an acute infection, and you have seen that this directly toward an acute, and in addition to coryzal symptoms, running nose and so on, it gives you an impression that this might be a viral meningitis. She is fully orientated and her observations are stable, okay? So look at the CSF. The CSF, the appearance is very clear. So it confirmed the possibility of a viral meningitis, okay? White blood cells are 150 cells per microliter, primarily lymphocytes. So it supports the diagnosis of viral meningitis. Glucose level is normal, more supporting the diagnosis of viral meningitis. So this is a clear presentation of a patient who is infected, who is suffering from viral meningitis. Okay, so the CSF analysis in viral meningitis, as we already insisted, that you look at the appearance should be clear. The opening pressure should be normal or slightly elevated. White blood cells will be elevated, but primarily lymphocytes. But sometimes at the beginning of the infection, you can have increased number of neutrophils. The glucose level should be normal, so it means that above 60% of the serum glucose. However, it might be low, especially in HSV infection. If the patient is infected with human simplex virus, herpes simplex virus, with a herpes simplex virus, that is HSV, the glucose level might be low. The protein level is elevated, but it's not extremely high, like in the case of acute bacterial infection. So what further investigation you can do when you suspect viral meningitis? You can send CSF for PCR to look for various viruses, mainly herpes simplex virus or varicella zoster virus or any other viruses that are able to cause acute viral infection. You also have to do imaging, CT or MRI, just to rule out other intracranial pathology. So those are the common etiological agents causing viral meningitis. Mainly we have HSV, it can be HSV1 and HSV2. We can have enteroviruses. We have varicella zoster virus, we have mumps, we have HIV, we have adenoviruses. So those are the commonest viruses that cause acute viral meningitis, okay? So in terms of treatment, I just want to emphasize more on the indication of acyclovir, okay? So we might know that acyclovir should be indicated mainly in patients who will present with encephalitis. And we should be aware of the fact that clinical features of encephalitis can overlap with those of meningitis. Okay, so patients with acute encephalitis syndrome, acute once they will present with acute onset of fever and a change in mental status like confusion, disorientation, coma, and inability to talk, or somnolence, or abnormal behavior greater than that is what is seen with usual febrile illnesses. So those are the patients. If you suspect those patients with encephalitis, then you can manage them using acyclovir in addition to the antibiotic therapy that you can put in this patient. So acyclovir is mainly added when you have also a case of encephalitis. So some of the patients will present with what we call a meningoencephalitis. Okay, so acyclovir in children and adults, you can use 10 milligram per kg, 8 hourly. And in neonates, it's mainly 20 milligram per kg, 8 hourly, intravenously by infusion over 1 hour. So you can use encephalitis. So this was our first part of this lecture series on meningitis, and this is mainly about acute meningitis, and we have discussed both bacterial and viral meningitis. So follow us on our second part of this lecture series, where we will now discuss mainly chronic meningitis, and where we will discuss cryptococcal meningitis, that is fungal meningitis, and we will also discuss tuberculosis meningitis. Thank you and goodbye.